which is observed in clinical practice, and this is something which is often missed in terms of evaluation and management. So when we talk about electrolyte homeostasis, we need to understand that the most important role of electrolytes like sodium is to maintain the serum tonicity. And it's the balance between the tonicity and the volume which makes very, very important. And if you have an abnormality with regards to your tone or your volume, you can have an abnormality which is there. So basically, if you talk about a sodium level, it depends upon how much sodium you have and how much water you have. And usually it is the free water which is a major determinant with regards to your overall status rather than the absolute sodium levels. So free water deficiency will be the major cause of hyponatremia, and free water excess will be the major cause of hyponatremia in that regards. Now the water level is determined by thirst and a combination of urine output. Basically, you have a balance between the water which is coming in from the intake, and then you are losing the water which is there from the kidneys. And in situations wherein you have got dehydration, your tone is increased, the body will start sensing the OVLT and the subfollicular organ, which are responsible for the osmoreceptors in the brain, will start looking at it, and they will produce ADP. They will increase thirst as well. Now this ADP will then go down and decrease the urinary excretion of water, increasing blood volume, and therefore will compensate on that. So the major osmolar response is through ADP. The major volume response is basically through the renin-angiotensin-aldosterone system. Now this system basically controls the sodium excretion. It decreases sodium excretion and increases potassium excretion. So conditions associated with decreased RAS activity will basically present to you with complaints of hyponatremia and hyperkalemia, while increased RAS activity will cause hyper or normal sodium and a low potassium in that regard. So sodium potassium basically go side by side in terms of problems and conditions that you see. On the other hand, if you have an increased volume or an increased sodium level, your atrial natriuretic peptide will come into the picture, and this will cause natriuresis. So hyperaldosteronism will cause hypernatremia, but that hypernatremia will be limited by the effect of AMP, which will cause loss of sodium. So the major manifestation of aldosterone excess is actually hypokalemic alkalosis and not hypernatremia or fluid edema. Now, what we need to understand is that the potassium is there both in the cells. This is what Dr. Vijay told us when we were discussing about DKA, and there is an exchange of potassium and sodium with regards to the sodium-potassium ATPase. So situations in which the sodium-potassium ATPase activity is more, like insulin, like metabolic alkalosis, like hyperkalemia, the potassium will go into the cell, and therefore the extracellular potassium may not be a good marker of overall potassium status in that regard, and insulin can really increase that, as could alpha and beta agonists. Now, in this context, we need to understand how the variations in sodium levels can have an impact on the cells. So the major thing that we remember is that sodium is the main regulator of tonicity. It ensures how much is the tone. So if you have situations wherein the sodium level is going down, there would be fluid which will go inside the cell, which will become more tonic as compared to the exterior. And this will cause cell swelling, resulting in features of cerebral edema like confusion, other problems, irritability, and other things which will happen. If it is severe, it will present with coma, seizures, and distress. If it's moderate, it will present with nausea, headache, and confusion. The identification of acute severe hyponatremia is essential because this is a life-threatening condition, and in this you have to do immediate correction. For other conditions, you can actually manage with a slower and a gradual correction which can happen in that regard. Now, over time, the brain cells compensate by taking off their idiogenic osmoles, and therefore their size becomes normal. So chronic hyponatremia, the symptoms become less, but they can be there like weakness, gait instability, cognitive defect, and other factors. So therefore, the manifestations of hyponatremia not only depend upon the level of sodium, but also in terms of the rate of fall. And this is something which is very, very important to understand from a clinical perspective. Now, if you correct this sodium levels very rapidly, what will happen is that there will be a sudden shrinkage of the cells because these cells were now accustomed for a low sodium. Now the sodium goes up, you will have a shrinkage of cells. So the acute response of hyponatremia is basically edema, and our response to therapy is shrinkage of these cells which are there, and this will be very, very dangerous. So do not correct acutely hyponatremia in most settings. Hyponatremia, on the other hand, basically will cause increased sodium. Fluid will come out of the cell and cells will start to shrink. So acute manifestations are altered sensorium, seizures, and hemorrhage. While with correction, what will happen is that the osmoles will be produced and this will balance it off. And if you correct it rapidly, you will have problems. So chronic presentation is with failure to thrive, dehydration, fever, typically for nephrogenic DI. And if you treat it inappropriately, you will have cerebral edema. So hyponatremia causes cell shrinkage and hemorrhage in the acute state. Correction causes cerebral edema. And this is something you have to be wary about. Now, what about the effects of potassium? Potassium is very important for renal concentration, for cardiac conduction, for cardiac contractility. So conditions associated with hypokalemia will cause abnormality in concentration causing polyuria, abnormality in cardiac conduction causing arrhythmias, and decreased cardiac contraction, and these could be big problems which will happen. So hypokalemia presents with nephrogenic diabetes insipidus, cardiac arrhythmias, spasms, and paralysis. On the other hand, hyperkalemia will cause cardiac conduction defects and contraction abnormality, arrhythmias, and asystole, along with paralysis. Now, serum sodium we have to assess at a right time, so this should be done any time of the day. The caution here would be to avoid after strenuous exercise, because that can cause a lot of changes in sodium levels. They are high with seizures, so you have to be wary about that. False diuresis will happen if there is an excess amount of protein, lipids, or glucose levels that will cause pseudo hyponatremia, and levels can be high if there is hypoalbuminemia. So you have to do it in that context. In that regards, normal range is 135 to 145. If levels are less than 130 or more than 150, we are bothered about evaluation. Potassium levels, of course, can be done any time of the day, but very importantly, potassium is an intracellular ion. So you should be cautious that it should not be taken with hemolysis. It should not basically happen with a lot of tourniquet insertion or a standing sample, because these situations will cause falsely high potassium levels in hemolysis, and if you have high count, it can cause both hypoglycemia as well as hyperkalemia, which you have to be wary about. Very importantly, blood gas analyzers will typically decrease the potassium by around 0.4, which you have to be very, very careful about. And very importantly, if there is a tourniquet used, a squeeze sample, or a high cell count, your potassium levels may go up in that situation. So what you need to understand is that potassium levels tend to be higher in preterm neonates and term neonates, and therefore differential criteria for both hypo and hyperkalemia should be considered in that regards. As we already discussed, that this is affected by other factors. Now, this is very, very important slide to really concentrate and understand about sodium and potassium interplay. Usually, in a body, the sodium and potassium go opposite. So if your sodium levels is high, you expect the potassium to go down. This is basically a classic presentation of a RAS excess. This could be something like a Bartter syndrome, something like a form of Liddle syndrome. It could be a form of Gentleman syndrome, in which you've got more RAS, high sodium or high normal sodium and low potassium, which will happen. On the other hand, if you have hyponatremia with hyperkalemia, it means that there is a RAS defect, which basically includes adrenal insufficiency, aldosterone insufficiency, aldosterone resistance, congenital adrenal hyperplasia, a classical salt wasting. Very importantly, isolated mineralocorticoid deficiency will cause more hyperkalemia. Isolated glucocorticoid deficiency will cause hyponatremia. A combined glucocorticoid mineralocorticoid deficiency will cause severe hyponatremia. So if your sodium levels are around 100, 110, you have lost both glucocorticoid and mineralocorticoid excess. If your potassium is above 11 or 10 and sodium is 120, this is a mineralocorticoid problem. And if your sodium is low, potassium is normal, this is a central problem of cortisol in that situation. Now, there could be only one condition if your sodium and potassium both are high. This is Gordon syndrome. And if your sodium and potassium both are low, In that situation, you have to start thinking of tubulopathies, diarrhea, or diuretic use in this situation. So now we'll just go through quickly about the various disorders. So hyponatremia will happen if you've got too much water or too little sodium. If it is because of fluid overload, you will have hemodilution, low uric acid, low PCV, person will be U or hypervolemic, while if it is because of a sodium loss, it will be high uric acid, a PCV will be more, there will be dehydration in that regards. The typical causes are fluid overload because of a cardiac disease, nephrotic syndrome, CLD. It could be because of SIADH or an endocrine defect. Now, very important to remember that cortisol inhibits AVP secretion and action. If you have cortisol deficiency, you will have more AVP there, causing a SIADH like picture, and therefore cortisol deficiency has to be excluded in everybody who comes to you with this picture of SIADH, without which there could be confusion in that regards. RAS defect will cause hyponatremia with hyperkalemia, while tubulopathies will cause, or diuretic use will cause hyponatremia with hypokalemia. Cerebral salt wasting will cause increased loss. Now, sodium manifestation will depend upon two things: how much is the sodium and how rapidly is it falling. So typically till around 125, 30, there is no symptoms. Then we have apathy, irritability, nausea will start appearing, headache, drowsiness around 120, and less than 110 seizures. So if you have these acute severe manifestations, this will be the time when you have to correct it immediately in that regards, and you have to be careful about it. Rate of fall is very important. So when you're assessing somebody with low sodium, look at hydration. If there is too much hydration, it is free water excess. If there is too little hydration, it is sodium loss. The other thing to look at is pigmentation, which suggests adrenal insufficiency, DSD, which will suggest 21-hydroxylase deficiency, and micropenis, which will indicate hypopituitarism. So if you want to classify, look at these parameters. If there is too much fluid, you are basically looking at a low amount of uric acid. Now, uric acid is a unique molecule that its excretion depends upon the volume. More volume, more excretion, low uric acid. So if you have a low uric acid, it is a fluid overload situation or SIADH. High uric acid is associated with diuretics, RAS defects, renal failure, and diarrhea. Urinary sodium should be less than 25 in anybody who has hyponatremia. So if the level is more than 25, it means a renal loss. Potassium, as we discussed, should be ideally high. If you have low potassium with low sodium, think of diuretic, gastrointestinal loss, or tubulopathy. Hyponatremia, hyperkalemia is suggestive of a renin-angiotensin-aldosterone defect. And again, hemoglobin, you will look at hemoconcentration in that regard. So the approach to hyponatremia depends upon excluding pseudo-hyponatremia. Look at fluid status, too much volume, think of a fluid overload. Euvolemic, exclude CAH and cortisol deficiency and thyroid, and then you have SIADH. While if it's hypovolemic, look at urinary sodium. Less than 25 is GI loss, more than 25 look at potassium, low is tubulopathy, and high is a renin-angiotensin defect. So basically, you're looking at volume and potassium, and that's giving you the clue in that regards. Now, management is mainly divided by symptoms. If there is acute severe hyponatremia, then only you should give a 3% saline and maybe infusion also, only till they are symptomatic. So your aim is not to rise the sodium levels to normal. The aim is basically to ensure that the symptoms go off and then you gradually build it up. For acute moderate, you have to avoid bolus. Rise should be less than 6 to 9. For chronic cases, there is no acute treatment and rise should be less than 6 millimoles per liter per day. We've discussed about hyponatremia, a word about hypernatremia, which is rarer but can be more dangerous than hyponatremia. It happens mostly because of free water loss associated with dehydration, very rarely because of sodium gain. The most common situation of dehydration is because of reduced intake, loss because of diarrhea or sweating, or diabetes insipidus in a chronic setting. Sodium excess can happen with high RAS or a sodium load, which is a rare situation in that regards. So you should suspect hyponatremia in somebody who has seizures and altered sensorium, dovey skin and dehydration, and fever. This is typical presentation between 6 to 12 months of age, with recurrent episodes of dehydration, failure to thrive, mental retardation, and intracranial calcification in the setting of a nephrogenic diabetes insipidus in that regards. So once you excluded salt lows in diabetes, look at urinary osmolality. Low urinary osmolality with high sodium means a concentration defect. Diabetes insipidus, look at AVP response. If it's present, it is central DI. If it's absent, it is nephrogenic DI. While if the urinary osmolality is also high, so you have concentrated blood, concentrated urine, all the load is being excreted via the urine. If the urinary sodium is low, it is GI or osmotic loss. If it's more than 25, it's a sodium load in that regard. Management again is a gradual management over 48 hours. Acute, you correct it over 9 to 12 millimoles, not more than that. Chronic, even slower. And you calculate the free water deficit, maintenance and ongoing losses, and then you do the protocol. We've got a specific calculator available in our MedEClasses application which will help you how to decide about what fluid to give for hyponatremia, and hyponatremia based upon dehydration level, sodium levels, and the age of the child. Now, if you can correct it orally, it is always better. Usually, if you're giving around half normal saline at 120% maintenance, it's good enough. But severe cases like 180, 190, you have to think of dialysis immediately. So now we'll discuss about two major conditions of sodium. We'll discuss a bit about hypokalemia, which can be there because of a RAS excess from an endocrine perspective or because of a tubular problem. So potassium can come down if there's an intracellular shift because of insulin or alkalosis, beta agonists, or drugs like chloroquine or channelopathies. If you're losing predominantly through the lower GI loss, like diarrhea or sometimes with upper GI vomiting and NG aspirations, and renal loss in the setting of metabolic alkalosis, diuretic use, tubulopathies, RAS defects, and RTA. So these will be the major causes that you will think about in that regard. Manifestations of hypokalemia are basically neuromuscular. As the potassium levels fall below 2-3, you start developing polyuria. Muscle problems start again around 2.5 to 3, weakness, ileus, and spasm. Paralysis typically is below 2.5, will be quite severe, and very low levels can cause rhabdomyolysis. Cardiac abnormalities typically less than 3. So you have to monitor for ECG changes in anybody who comes to you with hypokalemia. So the evaluation includes the pH. This is the most important investigation. Everybody who is hypokalemic should have metabolic alkalosis. If you have hypokalemia with metabolic acidosis, only two things, RTA and diarrhea. Look at urinary anion gap. If there is alkalosis, there are so many other causes to evaluate them. Urinary potassium, if it's really high, it suggests renal loss. Low suggests the extrarenal, like a diarrheal loss in that setting. Serum sodium, again, if it's high in normal, think of a RAS excess. If there is hyponatremia with hypokalemia, very, very rare situation, think of a GI loss or a diuretic use in that perspective. So hypokalemia, the key things to look at is the volume. If the volume is high, very unusual, this is RAS excess. If urinary chloride is low, it means that you are basically having a renal tubular or a diarrheal problem. If there is acidosis, it is RTA versus diarrhea. If it's hypomagnesemia, think of in the setting of malnutrition, diuretic use, or Bartter syndrome. And if there is hypertension with hypokalemia, think of a RAS excess situation like increased upper and middle corticoid excess, like 11-hydroxylase 17-hydroxylase deficiency, hyperrenism, or aldosterone producing adenoma. So basically looking at volume, urinary chloride, pH, magnesium, and blood pressure will give you the diagnosis for hypokalemia. So the approach for hypokalemia involves diuretic, malnutrition, GI, the common causes. Look at blood gas. If there is acidosis, look at urinary anion gap. If it's positive, it is renal tubular acidosis. Negative is a GI loss. Metabolic alkalosis, look at blood pressure. If it's normal, look at urinary calcium. High is Barter's, low is Gentleman. If the blood pressure is high, look at aldosterone. If it's high, GRA or aldosteronism. Low, it's DOC or 11-DOC. And if it's high, look at CH variant. So mainly blood gas and urinary calcium and BP will give you the diagnosis in majority of cases in hypokalemia. You can carry forward from there.
So, this 12-year-old boy, the case of diabetic ketoacidosis, and his blood sugar was 700 milligram per deciliter, and sodium was 126, potassium 3.6, and pH was 7.1. So, Dr. Neha, would you like to give correction for hyponatremia besides the usual management of diabetic ketoacidosis in this boy?
Okay, thank you, Dr. Riddhi, for the case discussion. So, as Sir has already explained, that the rise in blood sugar causes a false lowering of the serum sodium level. So, in this case, blood sugar is quite high, that is 700. So, I would first like to correct the sodium level for the given sugar level. So, if we go by the correction of sodium, the formula which has already been discussed in the class earlier, the corrected sodium is calculated to be as around 135.6, which is normal for this age. So the key messages before giving correction in such cases is that the causes of pseudo hyponatremia such as high blood sugar, lipid or protein should always be excluded, and a corrected sodium is a way forward for it. Thank you.
And that's very, very important in DK. Always continue to monitor corrected sodium. If it is not rising or if it is falling, you have a cause of concern.
Next case is 1 week old boy with sodium of 128 and potassium of 3.6. So here the photograph is not available, but the boy has micropenis on examination.
Dr. Akhilesh, I don't know whether he is there in the panel. Any connectivity issues. So basically, this is a 1 week old boy with hyponatremia, hypokalemia, sort of a low potassium, and he has got a micropenis. So anybody who comes to you with micropenis in first week of life, always start thinking of a multiple pituitary hormone deficiency. And if you see here, there are two things: sodium is low, but potassium is not high. Now, a lot of people often get confused that if you have adrenal problem, you should have a hyponatremia and a hyperkalemia. That is true for a primary adrenal insufficiency, wherein the aldosterone is affected. But in a central cause like multiple pituitary hormone deficiency, you will have a sodium which is affected while potassium is normal. So with micropenis, I would really like to think about a possibility of an MPHD. So there was no dehydration on examination. Blood sugar was also low. There was ketotic hypoglycemia. So ketotic hypoglycemia with hyponatremia, no dehydration. Always with micropenis, think of a SIDH picture. Cortisol levels were inappropriately normal for the level of hyponatremia, confirming the diagnosis of MPHD in that setting. So the key message here are that cortisol levels should always be measured in new-only hyponatremia, and cortisol below 550 is significant. Micropenis becomes an important indicator in that regard.
14-year-old boy with drowsiness and sodium level was 116. Child was euvolemic. Urinary sodium was 100 and urine osmolality was 300. So based on the feature of the euvolemic hyponatremia and high urinary sodium, diagnosis was of SIADH was made and fluid restriction is started. So Dr. Chetran, do you agree with this management?
I think looking to the investigational picture of high urinary sodium excretion and euvolemic hyponatremia, we always thought that this is a SIADH picture, but as discussed earlier by Dr. Anurag, that we should rule out cortisol as well as thyroid deficiency before stamping any patient as SIADH. So I would like to know the thyroid status as well as cortisol profile before going into the management of proper SIADH.
So the FT4 was low and the cortisol was also low. So this was now suggestive of MPHD in that situation. So I think your point is very valid, Dr. Chetan, that SIADH is a diagnosis of exclusion. Let's not rush in terms of diagnosis. So if we look into our own algorithms or our approach pathways, we'll really ask about any cortisol or the thyroid level in this setting before we label somebody as the SIADH in that situation. So the key message is, I think, here is that SIADH is a diagnosis of exclusion. Cortisol and FT4 is essential in euvolemic hyponatremia.
Next case is 3-week-old child with failure to thrive, sodium of 110, and birth weight was 2500 gram, and the current weight is 2600 grams. So that's severe failure to thrive. Child was dehydrated and hemo concentration was there. PCV was 62. Urinary sodium was high, 100 millimoles per liter, and potassium was also very high. So, Dr. Sajili, how will you assess this child? Sajili?
Hello.
Yes, Sajili, go ahead. Yeah, please unmute yourself.
Hello. Am I audible?
Yes, yes.
So this is a case of hyponatremia which is associated with dehydration. So this rules out pseudo-hyponatremia causes. So after that, one should look at the urinary sodium, as that will help us differentiate to know where is the sodium loss, whether it's in the GI loss or whether it's causing due to renal loss. So if we see in this child, he had a urinary sodium which was very high, and along with that, he had a elevated potassium levels. So this suggests that the child has a renal cause of hyponatremia and hyperkalemia. And with potassium high, it suggests a renin-angiotensin-aldosterone defect in this case. So,
And on examination, the child had atypical genitalia. So what do you think now are the diagnosis?
so with considering the atypical genitalia and hyponatremia, hyperkalemia at 3 weeks, most common cause of this will be a 21-hydroxylase deficiency. So in this patient, we should do a 17-hydroxyprogesterone. So as we can see, it's elevated. So this confirms the diagnosis of 21-hydroxylase deficiency, which most commonly presents around 3 to 4 weeks of life with salt wasting crisis and atypical genitalia in girls and normal genitalia in males.
Okay, so I think the key message of this is that if you have hyponatremia and hyperkalemia, think of a RAS defect, especially if there's an atypical genitalia.
Next case is 6-month-old girl diagnosed with cystic fibrosis based on the finding of failure to infection. And the level was high. There was no history of steatosis, and competitive electrolyte level, sodium was low and potassium was high. So, Dr. Neha, do you revise the diagnosis based on this electrolyte finding?
So as we can see from the clinical picture, that absence of steatorrhea raises the questions against the diagnosis of cystic fibrosis, which the child is labeled with. So going ahead with the algorithm that has already been discussed, slide change please. The first point to evaluate is the fluid status of any child who presents with hyponatremia. On evaluation, this child was noted to have hypovolemia and a urine sodium level which was more than 30 millimoles per liter. The next step in the evaluation is the potassium level, which was high in this case, and thereby we will evaluate the renin and aldosterone axis further. So since both renin and aldosterone were high, even in the presence of such a high aldosterone level, serum sodium was low and potassium was high, possibility of pseudo-hypoaldosteronism was kept, and with elevated sweat chloride, the systemic form, that is type 1, leads the most likely diagnosis in this case. So the key messages from this child is any child presenting with salt wasting and pneumonia, a possibility of PHA should be kept apart from cystic fibrosis, and renin and aldosterone levels help in making a diagnosis of pseudo-hypoaldosteronism, as in this case in which both renin and aldosterone were very high.
Now the big message is that PHA is a rare situation, but it is very, very difficult to manage. You have to consider high doses of salt, high doses of aldosterone and maybe other agents, and it's very, very difficult. If you have mildish hyponatremia and very high potassium, think of a pseudo-hypoaldosteronism as a mechanism in that setting. That's a big message I say. If for CH, the potassium cannot go very high. It is mainly going to be the sodium which will go to kill the child. That's the potassium will be around 7, 8. Here it can go up to 11 also. I think Neha, you saw a case of 12 recently.
Yes, we are currently managing a similar case in which the potassium went up to 12.8. But the serum sodium remained around 129 to 130. It didn't go that low, as sir is saying.
So this is a big message for PHA. I think that sodium will not go that low. Next case.
The next case is 1-month-old boy with reduced feeding, and birth weight was 3100 grams, now the 3200 grams. So there is a period of trial. Sodium was 124, potassium was high. So hyponatremia, hyperkalemia, 17 OHP and cortisol level was normal. PRA and aldo was high. So hyponatremia, hyperkalemia with high PRA, aldo with normal 17 OHP and cortisol. So Dr. Chetan, what will be the differential in this child?
Yeah, Dr. Chetan, unmute yourself maybe.
This is also showing salt wasting crisis in form of hyponatremia and hyperkalemia, but with normal 17 OHP and appropriate elevation of the cortisol. So it is ruling out any steroidogenic defect. So next thing is to look out for the RAS excess, and aldosterone is showing 200. So it is inappropriate. It is appropriately high, but still aldosterone is high despite we have hyponatremia and hyperkalemia. So aldosterone is not working. So this is also a case of aldosterone resistance. So now we have to think regarding whether it's a transient or the permanent pseudo hypoaldosteronism. So if there is any obstructive uropathy or urinary tract infection, then it is transient pseudo hypoaldosteronism due to the UTI which precipitates the aldosterone resistance. So in this case, the urine RM showing plenty of pus cells in form of more than 100 WBC, and ultrasound confirmed the urinary tract obstruction. So this is a case of transient pseudo hypoaldosteronism in which urinary tract infection should be treated judiciously, and then this aldosterone resistance reverses.
So it's basically a tubular problem, not an aldosterone problem. Best would be to treat the infection and obstruction, it will improve. I think this is a very important message, and you also have a recent experience of such a case. What happened to that case now on follow-up? Okay, so
yeah,
this test
the case which I have was a 4-month-old boy presented with failure to thrive in form of 200 grams of weight gain over last 2 months, and presented with salt wasting crisis. Aldosterone was more than 100 as per the lab reports, and urinary culture showed Klebsiella, which is multi-drug resistance, and now I have treated with the meropenem and amikacin. Now the UTI has been resolved, and the salt content earlier, the sodium chloride requirement was 1 gram per day, and now it has come up to 200 milligram per day. So hopefully within the next few days, I am planning to take the salt off with the current sodium remaining approximately 140.
And that's a big message that always think of transient causes in this case.
Yes.
So the management of hypernatremia can be quite confusing in this setting, and as discussed, so many things have to be looked in. So we actually have in our mobile application a way to put in the weight, how much is the weight for the particular child, how much is the sodium required, or the sodium level, how much you want to raise, and you will get the answer in terms of how much fluid is required. So this becomes much simple. Otherwise, you used to have this calculation which was done earlier.
Next case is 3-month-old girl presented with hypometric sodium. Sodium level is 170, potassium is normal, urine osmolality is 110, and he was advised the water deprivation test. So, Dr. Sajili, do you think a water deprivation test should be advised in this girl?
So, water deprivation test should not be done in this test, in this child, as the child is already having altered sensorium. The serum sodium is very high of 170. That requires urgent management. And along with the serum sodium being high, the urinary osmolarity is very low. That confirms the diagnosis of diabetes insipidus, and there is no need to do any water deprivation test, as it will aggravate hypernatremia and can be life-threatening in this patient.
So, because water deprivation test was advised, say developed the seizure, and because of the very high level of sodium. Now, AVP response was, AVP test was done in this child and found the diagnosis of central venous. So, the key messages are not to do water deprivation test in any patients who are presenting already with the hypernatremia with the serum sodium of more than 145 and concentrated urine.
So I think the big message out here is that if you have concentrated blood and dilute urine, it's only DI. That's pretty much it. Sodium beyond 145. You have a good concentration of urine. If it's not there, you have to think of a possibility of DI.
14-day-old girl with failure to thrive, birth weight of 2600 gram, and now is she has lost 2300 gram, and she was on breastfed. Sodium level was 180, it is 1000, so there is appropriate response to high serum sodium level.
So Dr. Akhilesh, I think, hasn't joined us yet. So the key message basically here is that this is a child in which we actually have level of we have already seen that this child has got a weight loss, sodium is also high, urinary osmolality is high. So this child is actually losing sodium appropriately, so there is no issue in terms of concentration. The major problem is that there is too much load for the body to handle. So what this condition is basically is what we know as breast milk related hyponatremia. Now this condition is primarily seen in primigravida infants who are not, the mothers are not really aware about how much feeding is required for the baby and how do we feed them, and they're not sure the baby look contented because they are okay, but they're not passing enough urine, they become severely dehydrated. A very critical condition to consider. Always think of this condition in a newborn baby who has not regained the weight in this situation, and you have to be cautious in that regards to evaluate and management setting. So I think this becomes important from that regards. So the big message probably we'd like to give at this point of time is that you have to think of a breast milk related hyponatremia in the setting of somebody who has dehydration, and in this setting you have to be very cautious in that regards.
The next case is 13-year-old boy with encephalitis, and he was on ventilator. He had polyuria of 10 ml per kg per hour, and sodium was very high. Urine osmolality was only 120. And post vasopressin challenge test was done, and post ABP the urine osmolality went up to the 200. So there is more than 50% rise from baseline. So this is the case of central DI. So how will you manage this child, Dr. Neha?
So as you said rightly that this is a case of central DI, so development of polyuria in a patient with CNS insult should always raise the possibility of widespread neurological insult compromising ABP release. So as we can see, there is high sodium with low urine osmolality confirming the diagnosis of DI. And also, since there is a rise in urine osmolality, which is more than 50% after giving ABP injection, it more or less confirms the diagnosis of central DI. So two options that we have in the management is either to give fluid only, or to manage the patient with fluid therapy along with ABP infusion. So ABP infusion is started at a rate of around 1.5 to 10 milliunits per kg per hour. We should always start with a low dose and then taper according to the urine output. While fluid only therapy, we need to balance the therapy according to the sodium levels. With ABP, there is always a high risk of sudden drop in sodium, while with fluid only therapy, there is a risk of sodium being high always. So ABP infusion, if you want to use, you should constantly monitor the sodium every 4 to 6 hours to avoid the risk of developing sudden hyponatremia. And this could be a harbinger of brain death, so parents should be counseled accordingly. So key messages which this case tells us: the sudden onset of polyuria in a child with brain injury, suspect brain death, and fluid replacement or ABP infusion, depending on the monitoring that is available at your center, remains the management of choice.
Usually the prognosis is very, very grim in this situation. So you have to, as Dr. Neha said, you have calculated and explain them in detail. Again, the fluid management in hyponatremia will be complicated. So we have developed the simplified formula in which you just have to feed the weight, the serum sodium levels, and the desired rate of sodium rise you want to increase, and you will get the amount of fluid or sodium you're giving. General principle is corrected over 48 to 72 hours with a sodium concentration typically of around half normal saline, and this has to be corrected with the aim of not increasing more than 6 in chronic and more than 9 to 12 in acute hyponatremia.
Next case is 2-month-old boy with failure to thrive. Potassium is 2.8, so there is hypokalemia, and blood gas showed metabolic acidosis, base excess of -16, and anion gap was normal, that is 12. So, and this boy also had history of diarrhea. So, main differential would be the diarrhea versus RTA because there was significant failure to thrive. So, Dr. Sajili, how will you differentiate these two conditions?
The main cause of metabolic acidosis with normal anion gap is diarrhea or RTA, and to differentiate between them, we can use an urinary anion gap. In diarrhea, there is loss of chloride, so the urinary anion gap tends to be negative, whereas in RTA, the anion gap is positive. So this will help us differentiate between the two.
So I think very big message is that usually hypokalemia causes metabolic alkalosis. If you have hypokalemia with metabolic acidosis, think of two things, RDA and diarrhea, and look at urinary net charge, which is a marker of ammonium production. So in the setting of diarrhea, you expect that the ammonium production should be more and your anion gap will be negative, while in RTA the ammonium production is defective and the anion gap becomes positive in that case.
Next case is 3-month-old girl with failure to thrive. Potassium is 2.2 and birth weight is there is significant weight loss. Only 700 grams she gained in the 3-month period. There was metabolic alkalosis, pH of 7.54, and blood pressure is normal for her age. So I
think this again is a case of persistent hypokalemic alkalosis that we are seeing early onset of birth. So again, as we said, if you have alkalosis, the first thing is to look at blood pressure. If the blood pressure is normal, in this case, we have excluded all the aldosterone excess causes, and there is nephrocalcinosis. This is a classical presentation of Bartter syndrome, and we have to treat them with indomethacin, and there will be a response. So always consider Bartter syndrome in normal BP, hypokalemic alkalosis, and they can be quite severe with early onset hypercalciuria and nephrocalcinosis.
So the next case is 8-year-old boy with early puberty, and height was advanced 134 centimeter, pubic hair stage were 4, and the blood gas showed the metabolic alkalosis with hypokalemia. Potassium was only 2.6, urinary chloride was high, and blood pressure was above 95th percentile for his age. So Dr. Chetan, what will be the diagnostic possibility in this boy?
Again, we are dealing with the early puberty, that is high androgen production before the age, as well as low potassium suggestive of increased RAS activation in the presence of alkalosis. So now we have excess aldosterone and excess androgens. So these two combination leaves the possibility only of a steroidogenic defect in form of 11-beta hydroxylase deficiency, because it will cause excess aldosterone action by DOC, which will result in the hypokalemia as well as hypertension, plus excess androgen will result in the early and precocious puberty.
And the very interesting point in this case was that there was actually cryptorchidism. This was actually a XX-DSD, which is a common presentation in 11-hydroxylase, who are missed at birth, who was so virilized to present like a male appearance. So always if you have cryptorchidism, always if you have hypertension, always if you have hypokalemia, think of these rarer causes of 11-hydroxylase deficiency. The key message is hypertension and alkalosis is CH, and XX-DSD, this becomes 11-hydroxylase deficiency. Do not recommend the routine boluses of calcium. What we basically advise is that we should have a continuous infusion of calcium, because that will not cause a lot of changes which may happen with regards to the calcium levels, because otherwise there will be a confusion in this setting that we have to be careful about. Now the next question is from Dr. Neha, at what level of sodium we start free water deficit? So basically we have to consider free water deficit. So typically when we talk about hyponatremia, I'm going to consider about more than 160. In that level, we should start thinking of 4 ml per kg of free water deficit, which is in addition to the saline loss. So this becomes important in that regards. So Dr. Lokraj Shah is asking, do we need to send cortisol level in every hyponatremic newborn in NICU? So if there is persistent hyponatremia below 130, I think you should definitely start thinking, because there's also a concept of hypocortisolism of the illness, and that transient hypocortisolism because of this stress illness is an important cause of delayed recovery, hypertension and hyponatremia, which you have to be aware about. There's also a transient hypocortisolemia of prematurity, and all these cases will benefit if you give cortisol. So I would say if there is significant hyponatremia, there is no other clear-cut cause. Levels below 130 persistently, think of doing a cortisol, and that's very, very important. Dr. Neha is asking, how are you saying the percentage of dehydration clinically? Yes, so we are usually talking about clinical dehydration that we are looking at, and this is how we will be focusing in most cases. Often, clinical assessment may be difficult to really address these issues. So if you are in doubt in terms of hydration, looking at uric acid levels, looking at hematocrit levels will give you an idea in that regard. So if